Awesome. So hello, everyone. Good afternoon. Thank you for joining us today. It is my pleasure to introduce our guest speaker, Dr. David Sandberg, a truly remarkable figure in pediatric neurosurgery. Dr. Sandberg is not only an outstanding pediatric neurosurgeon, but also a dedicated husband and father of two. His passion for both his family and his work shines through in everything he does. He has made significant contributions to pediatric brain tumor research, an area that is incredibly close to his heart. His book, Brain and Heart, The Triumphs and Struggles of a Pediatric Neurosurgeon, is a personal reflection on his journey in neurosurgery, the challenges he's faced, and the rewarding moments that have defined his career. In it, he explores his experiences with difficult cases, the emotional toll of delivering bad news to parents, and his deep commitment to advancing pediatric neurosurgery around the world. Beyond his clinical and academic work, Dr. Sandberg has spent years teaching and mentoring neurosurgeons internationally, sharing his expertise in managing complex pediatric neurosurgery cases and improving care in underserved regions. Today, Dr. Sandberg will share insights from his career and his book, touching on his personal story, his work with pediatric brain tumors, and the life lessons he's gained along the way. Please join me in welcoming Dr. David Sandberg. All right, Dr. Sandberg, you can take it from here.
Jake, thank you so much for the kind introduction. And I want to thank Jun Kim and Ankush Chandra also for inviting me to speak to you guys today. I'm going to talk about Brain and Heart, the Triumphs and Struggles of a Pediatric Neurosurgeon, the book that I just wrote. But really, this is just a means of sharing my journey and hopefully providing some tidbits of wisdom to you guys who are earlier in your journey than I am. So the first thing I'm going to start with is why did I write a book? I'm a busy pediatric neurosurgeon, or at least I was until today. I'll get to that later. Number one is an accumulation of great stories over the years. You know, we see some incredible things on a daily basis. And so many times I've thought to myself, wow, people would be amazed if they knew that things like this actually happened within the walls of a hospital. I started writing notes over the years, just in a Microsoft Word document, just jotting a few notes about particularly interesting patient stories in case I wanted to write something one day, which I didn't really have a vision like I'm going to write a book or something, but I thought maybe I would write some short stories or something at some point. There are many books that are written from the patient's perspective, what it's like to go through horrible diseases as a patient. There are actually few books that share the doctor's perspective and specifically share the doctor's perspective honestly. I have many difficult conversations with families as a pediatric neurosurgeon, and I choose my words in those conversations very carefully. And I've often thought that it might actually be helpful if parents, upon hearing the worst news about their child or other difficult conversations, knew what actually went through my mind as I was having these conversations, as I was having shared experiences of things that are horrible for families to go through. And in writing the book, I think, it really provides a perspective to parents about what their doctor's thinking in many circumstances. Helping students to decide whether to become neurosurgeons. I think that's really important. It's particularly important for this group. You guys are students trying to figure out what you want to do. And I think that this book dives pretty deep into the emotions I feel, what goes into the training of a neurosurgeon, what goes into a day in my life, and I think might be truly helpful for those considering neurosurgery or other very challenging careers to know whether you're cut out for it or not. And then to help residents and young neurosurgeons who've chosen the same path as I am learn from my experiences. And as I've gotten older, I've started to think about my legacy, about what is going to be left behind after I'm gone. And all of that is incorporated into this book. So the target audience, number one, would be families of children with neurosurgical and other conditions. Number two would be students of any variety who are interested in medicine, college students, med students, residents, and even neurosurgical colleagues. And then just anyone who's interested in fascinating medical stories, particularly those surrounding the doctor-patient relationship. So in terms of the title, Brain and Heart, The Triumphs and Struggles of a Pediatric Neurosurgeon, when we think of neurosurgery, we think of, at least I think of, first of all, the amazing things that the brain does, all the signals that enable us to do all the things that make us human, that pass from one cell to another. that are disrupted by neurological diseases. And we think of precision in trying to target specific areas of the brain using frameless stereotaxy, using robots, all the tools and toys at our disposal. And we think of brain surgery as very precise, right? But in truth, if you put five neurosurgeons in a room, for many cases, there's great disagreement. There is so much of what we do that is not written in textbooks or not adequately written in textbooks. There is so much of what we do that is not based in good science, in randomized controlled clinical trials comparing one modality of treatment versus another. And a lot of what we do is based on personal experience. It's based on what we were taught when we were residents ourselves. It's based on gut feelings, and it's based upon our heart. It's based upon the emotions that we feel. And so when I'm talking about the heart, I'm of course not talking about the organ that pumps blood through the body. I'm talking about the heart in the metaphysical sense of this as the center of our emotion, the center of love. And also, you got to deal with a lot of heartbreak in neurosurgery and in many other subspecialties, and particularly in pediatric neurosurgery, because everything is heightened when it involves tragedies that are involving a child. So the triumphs and struggles is because a career in neurosurgery, and particularly in pediatric neurosurgery, you really experience the highs and the lows, and the highs and the lows are very extreme. The highs, most surgeries go very, very well. Some are quite dramatic, and you literally can feel responsible for saving the life of a child. And the power of doing that in terms of the relationships you build with families, you save a child's life. You are forever a part of the family, of that family who has that child. And I feel like I'm a part of thousands of families who consider me to be one of the most important people that has ever entered their lives. And the struggles. We get the good, but we get the bad and the ugly too. We do operations that make patients worse. We have surgical complications. Every surgeon does. And you have to accept that you're going to make somebody worse after surgery than they were before, even with your best efforts. And it's particularly hard to swallow that when it's a child and their whole life is in front of them. So I begin with chapter 1, talking about unpredictable outcomes in neurosurgery. And I do that to show the lack of precision of what we do. And I picked what should be the most straightforward, easy case, right? It's an epidural hematoma. This is chapter 1. The name of the patient is Garrett. I use his name with his and his family's permission. He was in an ATV accident without a helmet and was airlifted to our hospital. And by the time he got to the hospital, he had this CT scan, which showed a large epidural hematoma with midline shift. Clearly an operative case, right? And it's a life-saving case, except for the fact that when I examined him, my examination did not elicit any signs of brainstem function initially. His pupils were large and non-reactive. He had no corneal reflex. He had no gag reflex, and he had no response to deep, painful stimuli, and he wasn't breathing above the ventilator. And so we typically will not operate on a patient like that. That patient is either brain dead or very close to brain dead. But his CT scan looked so good, and it was such an easily treatable problem. I pinched him 4 or 5 times, and he didn't do anything. And then finally, the last time I pinched him as hard as I could, he extensor postured, meaning he wasn't technically brain dead. So then I'm in the impossible situation. This kid is likely to have a horrible outcome. I've seen so many patients like him as the, neurosurgeon in a very busy level 1 trauma center for children. And many of them are in beds for the rest of their lives, fed by G-tube, not responsive to, their families. They don't follow commands. They require 24-hour nursing care, something that many of us wouldn't sign up for ourselves or for our children. And the likelihood of survival is very, very low. So I detailed the discussion I went with the family. I wound up taking this kid to the operating room, and he's absolutely perfect. He has no neurological deficits. He finished high school. He was on the golf team in high school. He went on and got a job. He is training in a nuclear power plant, and he's a happy, functional kid, and he's absolutely normal. And to his parents and the rest of his family, I'm the hero. I saved his life, right? And they have nothing but gratitude towards me, bringing me gifts every year, singing my praises. But his case haunts me because when I'm honest, I advise the parents that if this were my child, I would not offer surgery. that his neurologic exam was so poor. I wound up doing the surgery, but I gave the wrong advice. And, I question sometimes, are there other patients like Garrett who I didn't offer surgery, whose life could have been saved, and who might have had better outcomes than I thought? And the answer is I don't know. I can't think of any specific cases, but they certainly could be out there, and that absolutely haunts me. I think, in terms of training, mentorship is, absolutely crucial. And I've been so fortunate to detail, excuse me, to have the most wonderful mentors in neurosurgery. And chapter 2 details my road to becoming a pediatric neurosurgeon. I was a medical student at Johns Hopkins. Donlin Long was the chairman there. He was an elite figure in neurosurgery, very well respected, but very kind to medical students. He took me out for coffee in between one of the cases just to get to know me. And that might seem like a little thing, but that half an hour or 45 minutes meant the world to me. So when all of you guys become big attendings, remember to be kind to students who are in your position, spend time with them. Um, it may make a massive difference in their career, and it may have made the difference between me becoming a neurosurgeon. Henry Brem is a gem of a guy. I know he was on um, your this webinar series recently. I worked in his laboratory, and he treated me with such kindness, and he was such an example of being a clinician scientist, of passion for research and brain tumors, and just of treating people well. He treated everyone with such respect and such kindness. And I was like, I want to be like that guy when I grow up. Reed Thompson was the chief resident. The neurosurgery service had so much passion, and the days were very long, but they went by so quickly because everyone was so passionate about what they were doing. And Reed's enthusiasm led me to make the decision to be a neurosurgeon. I trained at Cornell. I had a number of important mentors there. The first was Richard Fraser, who was our chairman. He actually left in the middle of my fourth year of residency, retired. Um, I remember certain pearls that he taught me even to this day. Phil Guton was the chairman at Memorial Sloan Kettering, which was one of the important hospitals that we rotated. And I was interested in brain tumors, and he was a huge mentor in that regard. Phil Stieg became my chairman and was an enormous influence on me. Is still chairman of Cornell after many years. And the most influential person in my career and really in my life outside of my immediate family is Mark Swadan, who was the pediatric neurosurgeon at Cornell when I was there. And I saw what an amazing technical surgeon he was, but above all, I saw the relationships he formed with families and how passionate he was about it. And I literally wanted to be exactly like him when I grew up, and I'm still trying to do so. I went on after residency, and I talk in the book about the life of a resident in the days before work hour restrictions and the controversies about work hour restrictions and all that I went through. I think it's interesting, especially for students who are considering the career, but also for families to know what their doctors go through before they wind up meeting their family member as a patient. I went on to Children's Hospital of Los Angeles, where I did my fellowship. Dr. McComb and Dr. Krieger were the two faculty mentors. It was an incredibly hard year. I took 3 days of vacation the whole year and did over 600 cases. It was one of the most wonderful years of my life. It was when I transitioned to really gaining the confidence that I can be a very competent pediatric neurosurgeon. I felt very battle trained after that year. Moving on to chapter 3, once I have given the background of who I am and how I became who I am, I get into the details of what my life is like and what the conversations I have are like. There are some people who might read these chapters and be like, this is not something I can do. This is too hard for me. And that doesn't make you a bad person or anything like that. It's just telling parents that their child has died or is going to die is very difficult, and it's not for everybody. The way I interpret it for me is somebody has to do it. The conversations are incredibly important. It's something that I put a lot of thought into, and it might as well be me. This is a family that I use their picture with the permission of the father, who's on the right. His wife on the left has passed away recently from a sarcoma, and their only child is Gus. I use his name with their permission, and he was a patient in one of my research trials with a recurrent ependymoma that came back no matter what we tried, multiple surgeries, chemotherapy, our research trials, and he passed away too. They passed away, the mother and son, within a month of each other, and he was the only child. So this father lost everything. He lost his whole family. And you can only imagine the conversation that I had with him, in which I had to tell him that our experimental treatment, which was his very last hope, didn't work and his child was going to die. Impossible to have that conversation, yet somebody has to have that conversation honestly with this father. And that's what this chapter is about. The strategies I use to have those conversations and the strategies I use to cope with those conversations myself. I'm really just giving you an overview, and then of course I'll answer questions about any of these things in more detail. The next chapter shows the beauty of our field, the rewards for saving the life of a single child. And I use the example of the most influential patient in my career. When I was a fourth year resident, during my research year, I spent a month and I went down to Honduras and I volunteered at the teaching hospital down there called the Hospital Escuela, where I took care of the poorest of the poor patients. And I came across this beautiful little girl, Marcella. I use her name with her family's permission and with her permission, um, who was an 8-year-old girl who presented with diabetes insipidus, bitemporal hemianopsia, and vomiting, and had this large suprasellar mass that down there they thought was a craniopharyngioma, but I looked at it and immediately, given the history and radiographic appearance, I knew that this was not a craniopharyngioma, that this was a germinoma, which has a 90% cure rate. Currently would be treated with chemotherapy and radiation. Back then it was just radiation, but even radiation alone had a 90% cure rate. And this girl was going to die in Honduras. And I called my mentor, Mark Swain, in New York, and I said, what should I do with this kid down here? This is a curable disease and she's going to die here. And he said, let's bring her to New York. And through a Herculean effort on his part and on my part, we brought this little girl and her mother to New York. The day before they were supposed to arrive, their housing fell through. They were supposed to have housing donated by a charitable organization, and it fell through, so there was nowhere to stay. Um, I'll tell you more about that. First, bring her to the hospital. We did an endoscopic biopsy. This is a picture of her surgery. We confirmed the diagnosis of germinoma. She received involved field radiation therapy, and her tumor literally melted away. It was gone. Um, and she spent 3 months in New York and then was ready to go back. As I mentioned, her housing fell through. And this is an example of when you give of yourself, how much more you get back in return. So I had no place to put this kid and her mom, and they were literally getting on a plane the next day. So I gave them my apartment, and I moved in with my girlfriend at the time, Amy, who's now my wife. And I was a very busy neurosurgery resident, and I would come and check on them in my apartment at midnight after I finished my day's work. And I would often find Amy, my girlfriend, on the floor playing with this little girl. She didn't speak any Spanish, and the little girl didn't speak any English, but they bonded, and I was like, wow, this is incredible. And it kind of was the final straw in convincing me that Amy was meant to be my wife, was meant to be the mother of my own children. So as a wedding gift to ourselves, we brought Marcella and her sister Catherine back. They were the flower girls in our wedding. And you can see how meaningful this is to us. There was not a dry eye in the house as they walked down the aisle. And then she survived 24 years and went on to medical school, which is incredible, with the goal of becoming a pediatrician. And the book details the story and what it means to save the life of one child. Unfortunately, this is not in the book because it comes after the book's publishing. It has a tragic and quite cruel ending. She died a month ago of a pulmonary embolus, 24 years out with not a cell of tumor in her body. She had shortness of breath. She went to the hospital. They correctly diagnosed a PE. They started her on anticoagulation. She seemed to be improving, and then she just died in the middle of the night, which was incredibly hard for me to handle, obviously impossible for her family to handle. But, showing both the beauty and the cruelty of the field that we have chosen. Chapter 5 deals with complications. I have a lot of strong feelings about complications. This is a picture of an intramedullary spinal cord tumor. in a child who walked into my office but never walked again after the surgery. And I detailed the story in my book, and I detail a few other stories about complications because there are no neurosurgeons who have no complications. And it's really, as I mentioned, hard to swallow when it's a child. You do your very, very best, and a child ends up worse than when they started. And what's so amazing is, take brain tumors, for example. The brain is so unpredictable, and brain tumors have been my area of focus. You can take two kids with the same appearing brain tumor in the same location of the brain. You operate on one of them, they wake up perfect. You operate the next day on the other one. You do the same operation with the same care, and the patient wakes up with a permanent neurological deficit. And you're like, I don't understand why this kid got the deficit and not the other kid. And it's hard to swallow. I have strong feelings about how complications should be approached. There are extremes which are unhealthy. There are some, if I have a surgical complication, I could be like, you know what? I'm a very experienced neurosurgeon. I've been doing this for over 2 decades. I trained at some of the finest institutions in our country. I've done this operation hundreds of times. I did my best. It's not my fault, and not think further about it. And I think if I did that, I probably don't deserve to be a neurosurgeon or maybe any doctor, type of doctor at all, putting that little thought into it. On the other hand, I've seen neurosurgeons become so paralyzed by their complications that they can't go on and treat the next patient, which doesn't do anybody any favors if they're, shying away from the difficult cases that they were trained to do. There's a happy medium where you present the case in morbidity and mortality conference. I talk about what that's like to present your worst day in front of 50 or 100 people, some of whom you don't even know, with slides and videos. I talk about that in the book. You reflect honestly about what I could have done differently or better. There's often something to be learned from these complications, and I've learned more from morbidity and mortality conference than from any other conference over the course of my career. Chapter 6 details a day in my life. These are my kids. They don't look like this anymore. Um, they are now 17 and 14. But I talk about, I'm a family man, and I have a huge priority of having close relationships with my children. And I talk about the challenges of being a neurosurgeon and having an incredible home life as well. I've been able to pull it off. I have not made it to every single soccer game that my son plays. He's an avid soccer player. I've missed a few things here and there. I've never missed a birthday or a really important occasion. And I have a wonderful and very close relationship with my wife and my two children. So it is possible. But I talk about the challenges and what a day is like in my life, both at work and at home. And I think that might be meaningful for those of you about to embark on this career who are wondering what your family life is going to be like, what your work life is going to be like. Chapter 7 just talks about some things that are of interest to the general public, particularly regarding safety, because so many things that I've seen in my career are preventable injuries and accidents from things such as non-accidental injury, child abuse, from injuries of kids not riding bicycles with helmets. I've never seen a serious traumatic brain injury in a kid riding a bicycle who's wearing a helmet, but I've seen so many kids die or have permanent neurological deficits from devastating traumatic brain injuries. I'm proud of one paper that I wrote, which talks about the social aspects. I wrote this with a medical student at the time, Joe Brewer, and a few of colleagues. Um, a social perspective on gun violence. Basically, had the kid get the gun, it was the gun locked up? Was there any repercussion for the parents? Sort of the social perspective, because a lot of what we see in neurosurgery are social ills. In chapter 8, I talk about my research, which has been an immensely meaningful part of my career. For the students out there, I think many wonder, can you be a scientist and a neurosurgeon at the same time? There's certainly pressure to do so though when you're applying to residencies, because the residency programs certainly want to train academic surgeons who have academic interests. But the question is, how many of those academic surgeons who are interviewing you actually have meaningful research careers? The answer is not all of them, but many of them do. My message is that, first of all, research is possible, even if you don't think it's something that you can do based upon your training. I was a history major in college. I had essentially no research background, And I have never been the smartest person in the room, in any room that I have been, whether it be in high school, college, medical school, residency, or as a faculty member. I have often been the hardest working or one of the hardest working. And all it takes is exposure to patients and having ideas. I've had one good idea throughout the course of my career. The idea is that patients with tumors that are formed within the fourth ventricle, namely medulloblastoma and ependymoma, we often do a near total surgical resection on those tumors, leaving a tiny bit behind that's stuck to the brainstem. Then they go on and get radiation, which is harmful to the developing nervous system, and chemotherapy, which is harmful to other body organs because you have to give it in such high dose to overcome the blood-brain barrier that it's toxic to many organs. My question was, why don't we just infuse drugs into the fourth ventricle and get high drug levels here, kill whatever cells remain, and not expose the body to all the other harmful effects of current treatments? So I tested this in a pig model. I'm going to speed up so there's time for questions. I'm almost done with the talk. Um, and I started putting catheters in the fourth ventricle in pigs and giving various chemotherapy drugs and measuring drug levels and looking at safety. I went on to do the same in non-human primates. And I'm proud that the work actually led to human clinical trials. This is a patient with a posterior fossa tumor on the left where the tumor is removed. There's a clean MRI on the right, but the image in the middle is the floor of the fourth ventricle showing a tiny carpet of tumor left on the floor of the fourth. That's not visible on the MRI, but I know it's there. We went on to non-human primate work. And then we had our first clinical trials where we infused drugs into the fourth ventricle in kids with recurrent tumor. My very first patient, who's mentioned in the book, his name is Jordan. I use his name with his permission, and his family's showed up with a massive tumor burden. The column on the top, the first three images show massive amount of tumor in the fourth ventricle, cerebellopontine angles, coating the cerebellar folia, lateral ventricles, and then the spine image shows a few spine deposits. It all melted away, not completely, but the spine tumors went away. The lateral ventricle got dramatically smaller. The posterior fossa tumors went away. He had a life expectancy of about 3 months. He wound up surviving 2 years. Unfortunately, the tumor then came roaring back and he wound up dying of his disease, but promising. But I had so many failures. And in the book, I talk a lot about the failures because what I'm most interested in is the doctor-patient relationship. This is Jocelyn, a little girl. You can see she has a crooked smile because she has a facial nerve palsy. She was the most adorable little girl. I would ask her to walk when I would examine her. She was in my research trials. We were giving chemotherapy into her fourth ventricle for a recurrent ependymoma. And when I would ask her to walk, she would skip down the hall. It was the cutest thing. And I would get very close to these research patients because it's not just taking out a brain tumor and then, seeing them in post-op care and then sending them on to an oncologist. I saw them, these kids, week after week after week and gave the infusions myself or my physician assistants did and just developed an incredible closeness with the family. And I talk about at the end of this, you get an MRI scan, the feeling of despair when the MRI comes across your screen and I could not focus on anything else. I'm hitting refresh, refresh, refresh until those images come up. And then seeing that this girl's tumor had laughed at what I tried to do. It had grown tremendously despite our infusions, and she was going to die of that disease. And the walk I had to take down the hall to go meet with her parents and tell them that this amazing little girl was not going to survive. Um, Tragic and cruel, but so important. The last chapter talks about my experiences in low and middle income countries, a hugely favorable and important part of my career. This is one of the first trips I went on to Guatemala. Patients lined up who've come from faraway villages with pediatric neurosurgery problems. We see lots of kids with hydrocephalus, huge heads that you don't see in the United States. Does anybody, I'm going to ask for the students, does any student know what this entity is? You can see the image on the clinical image and the MRI. Does anyone want to guess what this is?
A neural tube defect.
It is a closed neural tube defect, correct. Do you know what specific closed neural tube defect it is? I would not expect you to know this. It's very rare.
Uh, it's not myelomeningocele, like a complete myelomeningocele.
This is called a myelocystocele.
Myelocystocele. Okay.
Myelocystocele. Basically, the central canal of the spinal cord is open at the bottom, and the spinal cord is low and tethered, and it feeds into this huge skin covered lesion that grows and grows, and it's like a basketball on this baby's
Mhm.
back. These are the kind of things that you would never get this advanced in the United States before medical attention is sought. But this is the kind of thing you see. And I really focused on these trips, not just on doing surgeries, but on teaching it, the teach a man to fish concept so that you change the country forever and patients have access to better care. And that's the whole point. And so I want to talk briefly. I've been addressing this honestly as been speaking around the country. And I hope this never happens to any of you, but life throws all of us curveballs. And I have faced a curveball of my own. I've spent my career taking care of patients and being the doctor, which is much better than being the patient, and having the difficult conversations from the giving side of the relationship. Unfortunately, I, a number of months ago, started developing a tremor of my right hand. Today is my last day, actually, of work as a neurosurgeon, and this is meaningful to speak to you guys tonight. So thank you for this opportunity. I started developing a tremor of my right hand, and it's mild. It wasn't affecting surgeries because it's a resting tremor, and when my hands are in motion, it's not visible. So under the microscope, you would never know. But it started becoming more noticeable. It was noticeable in the clinic. My hand would just start shaking when I was talking to a family. I don't swing my right arm as much when I walk down the hall. And this is what's called a DAT scan. It's a confirmatory study. I'm the patient here. And you can see that in the basal ganglia on the right side of the brain, it's more robust than on the left side, corresponding to my right hand tremor, really confirming the diagnosis of Parkinson's disease. And so I have decided to retire. And I'm happy if it's helpful to you, to any of you, to talk about what that journey has been like for me so far, what I plan to do, and um, and what it's like to be on the other side of the curtain. So that is a summary. Um, and I'm happy to open this up for questions and talk about any of the things that I mentioned tonight.
Thank you so much, Dr. Sandberg, for giving us that absolutely incredible talk. I read the book and I loved every single page. So I've prepared a few questions for you, kind of directly coming from the book. Um, One of the ones that was important to me was, so you mentioned that honest and deep reflection on complications is essential to learn lessons that can prevent similar issues in the future. So as medical students, we're still in the process of learning and may not yet have the responsibility of dealing with major complications firsthand. How can we begin to cultivate this habit of deep reflection and critical analysis now so that we can make the most of every learning opportunity before entering residency and taking on these situations directly?
It's a great question. I mean, as a medical student, it's difficult to carve out a role on the service as a
Mhm.
medical student, but you can be a fly in the wall and take in as much as you can. The single thing that I would encourage you to do most as a medical student is whenever you can, if the attending will allow you to, or the resident, if it's a resident, accompany the attending when they have the difficult conversation about that complication. Be in the room when that attending tells that mother, your child is not moving the right arm after surgery and may never move the right arm again. And what you can do from that is you might look at the way that attending does that conversation and say, wow, that wasn't nice, that was harsh, it was too abrupt, it was whatever it is, or that was wonderful. Or there might be parts of the conversation that are wonderful and parts that are not. And watch a number of different attendings have difficult conversations about complications, about patients who've died, and take the best from each one of them and form your own style and take mental note of what works and what doesn't work. That's what I would focus on is the complications. As far as, you can also see the demeanor of the surgeons who have the complications and what attitude they bring, whether it be one of the extremes that I mentioned or that happy medium. That's
Mhm.
the best advice I can give for a medical student in that stage.
Absolutely. Thank you. Right. We do have a question from the audience. It says, how and when did you know that it's neurosurgery for you and not any other field of surgery?
Yeah, we all have our own path. As I talk about in the book, there are some who decide they want to be neurosurgeons when they come out of the womb. I was
Mhm.
not one of them. My path was My father was an ophthalmologist. He thought I was crazy to go into neurosurgery. He wanted to hand me his very successful um, private ophthalmology practice. I rotated through ophthalmology. I tried to like it, but I didn't love it. I wasn't passionate about it. And I always thought I got to do something I'm passionate about. I entered medicine thinking I wanted to do something in community public health, working with indigent patients. I had directed a homeless shelter in college, and I was very focused on being a doctor from the service perspective and had no knowledge or interest in surgery other than accompanying my father on some medical missions where he did eye surgery, which were really neat. But I thought I was going to be a primary care doctor, to be honest. In the emergency room, I saw who was triaged where, and the surgical patients were just more interesting to me. And then I saw it wasn't, being in the operating room wasn't the thing. It was, you're kind of a fly on the wall. You can't see. Um, but I was fascinated by the conversations between surgeons and patients. A patient comes and they have a finite problem that's very troublesome or life-threatening, and the surgeon tells them, I can fix this problem and here are the risks, or I can't fix this problem, but nobody can. Nobody else can either. And I found those conversations very compelling. So I'm like, I'm going to try some of these surgical specialties. I happen to rotate through neurosurgery. And because of the mentorship I was fortunate to receive during that 1 month of neurosurgery rotation, I caught the bug and I was like, this is what I was meant to do.
That's awesome. All right. Another question that relates to this. So you mentioned that one of your main motivations for pursuing medicine was the desire to provide care to underserved communities, and that you were initially concerned that neurosurgery might not allow you to fulfill this goal. So did your time serving abroad help you achieve this? And do you feel that you've been able to meet this goal in your practice in cities like Miami, New York, Los Angeles, and Houston?
Yeah, I mean, one of the nice things about being a pediatric neurosurgeon is you're kind of a public servant just by virtue of the fact that children are the poorest segment of society. You know, over half the patients in a major city, in any major city, in a pediatric neurosurgery practice are Medicaid patients or uninsured patients who are undocumented or whatnot. And you're providing a public service, just by going to work and doing your job, taking care of a lot of very, very impoverished and disadvantaged children. As far as the trips abroad, I mean, they were so meaningful to me. I went on about 20 trips abroad. The place I went the most was Haiti. I went there 10 times. Haiti is the poorest country in our hemisphere with by far, with poverty rivaling the worst poverty in the world in sub-Saharan Africa. You go there and you spend a day just driving around the city, let alone trying to do a neurosurgical operation. You realize how very lucky we are to live in this country, to have the equipment we have as neurosurgeons. I kind of need to go on one of these trips every 6 months to a year to remind myself of these things. And I come back, I'm not complaining about how sharp the micro scissors are or, what minor deficiencies there are in our amazingly equipped hospitals. Um, and the relationships I've formed have been very meaningful with neurosurgeons in these countries, trying to teach them how to perform surgery the way we would here in the United States.
Gustavo, do you want to ask a question?
Yeah, so I have one question here, and would be related to I would like to hear from you, doctor. Do you have one particular moment when you felt proud of finding the right words while breaking bad news to a family?
There's not one particular moment that I can pick out, but I have put a lot of thought into this, and I describe it in detail in the book. I think there are definitely things that are obvious things that are wrong to do. Like you never have these conversations standing up. You got to sit down. You have to be patient. You have to listen. I think the thing that I've done that I think is the most important in these conversations is to be kind and compassionate, but not give up honesty. There are so many doctors who are so afraid to give bad news that they have a hard time saying it. If the child is going to die, you have to tell the parents the child's going to die. You can't say that everything might be okay because that's cruel, right? It's not fair to those parents as hard as it is to hear. So you have to find a kind way to say it and you have to find a compassionate way to say it, but you got to say it. And so, again, I encourage you to look at others who are, participating in these conversations and listen to those conversations to see how it's done well and how it's done not well.
Thank you.
Um, And then we have another question from the audience that says, how are you handling the health curveball? Is transitioning a role in neurosurgery leadership an option in the short term?
Yeah, so it's a great question. Um, how am I handling it? It's been a long road. Um, So, at first it was kind of hard to accept. My symptoms were very subtle. I saw three neurologists um, before making a final determination of what to do. I was advised I could continue practicing neurosurgery, that medicines could treat the tremor, and I could continue practicing. My tremor is subtle and not present with motion, as I mentioned. But I never wanted to be like one of those athletes. You see professional athletes who are amazing in their peak and they stay on too long. And there are some neurosurgeons who do it too. There are some who operate well into their 70s or even beyond. Some of them can do it and they're terrific, but there are others whose skills fade and they're not as good as they were at their peak. And you kind of wish that they just retired when they were at their peak. I never thought that would be at 53 and it was hard to accept. But once the diagnosis was made, and I know that it's a progressive disease and I'm likely to get it worse over time. I didn't want to wait until I started having complications or people started noticing I was having a tremor. So I shocked the world and just decided to stop operating cold turkey and retire. It was very hard to make those decisions. It was very hard to tell my family, to tell my children, to tell my parents, my sisters. My wife was a great support to me. Um, Once I made those decisions, I kind of felt my happiness return and had those conversations. The worst was over. And I started thinking about what I wanted to do. There's not, a lot of people have said, oh, you should continue in neurosurgery, you should teach, you should do this or that. There's not really, I don't have any role models in that. I don't know any non-surgical neurosurgeons. And I felt that if I was trying to do it without the surgery, I'd really miss the surgery. I love operating on the brain and spine. And I didn't want to be a neurosurgeon without doing the main thing that neurosurgeons do, which is neurosurgery. And
Hmm.
so I may teach an occasional lecture. I'm still going to be involved in international medicine, but I'm choosing to have a brand new, likely non-medical second career in which I do something that's focused on childhood poverty. As I've mentioned, I'm really interested in social ills that I've seen in the hospital and outside the hospital. I'm interested in working with children and families who are homeless or, kids who are in the prison system or in foster care, um, and making a meaningful contribution to children. I can't do the surgeries anymore, or perhaps I shouldn't be doing them anymore, but I certainly still have my mind and I have my heart, my compassion.
Absolutely. Absolutely. And another question I had was when discussing being a neurosurgeon and a father, you mentioned first setting realistic expectations and second, trying to be as present as possible when away from the hospital and with your family. How did you go about being present and being able to leave work at the door when you are so heavily invested in the care of your patients?
I really kind of compartmentalize things. And as I talk about in the book, I'm not someone who's completely detached from my emotions. And I think it's okay to have emotions. It's okay to cry. I talk about that in the book. Um, but when I got home, I more often than not, sometimes I would share with my wife that I had a hard day or that, a child had died or something like that. But more often than not, I just moved into a different mindset. And I just got into dad mode basically. And I might have, hugged my kids a little harder on certain days than others just without telling them why. But basically, I was intensely focused on being present. There are a lot of parents, if you look around at parents, whether you're at a restaurant or you're in a park or wherever you are, there are a lot of parents who are basically on their phones all the time, right? They're checking their emails and their texts. If I had to answer a phone call for work because, I was on call, obviously I did so. But other than that, I was, not on my phone, on the floor, playing with the kids, changing the diapers, actively engaged. And I think that was super important.
Absolutely. Um, And then we have some more questions from the audience. So one of the attendees said, thank you so much for sharing your journey with us, both in career and in health. I am truly grateful for your openness in discussing this. I would love to know what kept you going when things got difficult in pediatric neurosurgery. How did you keep your fire to serve the people um, Sorry, just lost it for a second. Oh, sorry. How did you keep your fire to serve the people alive through it all? And thank you.
It was never difficult to keep going. I mean, I am someone who, over the course of my career as a pediatric neurosurgeon, I think I have more love for my job than anyone I've ever met, and such passion for it. I have felt so lucky to have the opportunity to take care of children. I've had plenty of hard days, but they were always overshadowed by the amazing successes and the amazing days that I had as a pediatric neurosurgeon. So it was never hard to continue for me. It was only gratitude for the opportunity.
Mhm. Fantastic. All right. June, do you have a question?
Yeah, Dr. Sandberg, first of all, thank you so much for the great presentation. We're nearing the end of our session, so we'd like to close by returning to the theme of mentorship.
Yeah,
As we discussed before, we both had the opportunity to be mentored by Dr. Bren and Dr. Tyler,
yeah,
who have, really shaped the future generation of neurosurgeon scientists.
yeah.
So what are the most enduring lessons you've taken from their mentorship, and how do you work to pass those lessons to the next generation?
I mean, there are so many lessons to be learned from a guy like Henry Brem. He's extraordinary. I'll tell you one story about him that you may not know. It just involves me. Um, I worked in his lab for 4 months. I was a, you know, I was a novice, researcher. I contributed very little. I got a couple abstracts out of it, never published a paper. And there were many students in his lab. But he's the kind of mentor who remembered me. And years later, over a decade later, I wasn't even in contact with him. He came to my institution as a visiting professor to the University of Miami. He must have looked up who was on the faculty, saw my name, remembered that I worked in his lab, and he put like 3 slides in his talk with my big picture on it, and he made it look as though I had done work in his lab worthy of the Nobel Prize, which was ridiculous because, I hadn't contributed that much. But basically, he was trying to bring honor to me at my own institution and make me look good. What a guy. I mean, what an incredible human being. The mentors that have made a difference in my life have taken time to spend with me. I think you got to earn it as a student, right? So I don't think even the best mentors give freely of their time to every student. I think, you know, there are certain things that you have to do as a student. You got to show up on time. There's nothing more annoying than making a meeting with a student and they show up 10 minutes late. It's disrespectful, right? So you got to show up on time or early. You have to have enthusiasm. You have to care. But if you have those things, then you know you'll see how meaningful it is to you, how well you're treated by certain people, and go on and pay it forward and do it to the next person. It's so meaningful and so rewarding.
All right. June, do we want to wrap things up?
Yeah, go ahead, Jake.
So I just wanted to give my deep appreciation to you, Dr. Sandberg. You've been an inspiration to me at McGovern Medical School. I've been to a couple of your talks. I've read the book, and I loved every single page in it. And it's just a very inspiring story to me that made me think a lot about my future, my career, and what I desire out of it. And it also gave me hope that one day I can be a physician who also is very loving father and husband. So I just wanted to say thank you so much from the bottom of my heart for everything you have given to the institution I'm a part of and the entire world of neurosurgery. So thank you so much for that. And congratulations on the retirement from today, because this was the last day. So
Well,
thank you.
thank you. Thank you very much. Thank you for the kind words. And right back at you. I've heard great things about you from within our institution. You are a rising superstar and you're incredibly articulate and very kind. And I think you're going to bring great things to the field. And my thanks to all of you for listening to this talk. And I really truly wish all of you the very best of luck. Godspeed.
Thank you so much, Dr. Sandberg.
Thank you,
Thank
Dr. Sandberg.
Good night,
All
everybody.
right.